Okay, good evening, everyone. Welcome back to our first webinar of the year. So I'm Dr. Betty Tay. I've been doing this webinar for about 16 months now, from 2020, end of the year to last year. And then I took a break for some time. So now we are back. And this year, I hope to do more nursing webinars. Just bear with me, because we are trying to actually create a way to give your e-cert, yeah. But we are learning on the progress also so it's work in progress and learning on the job. So just bear with us. But I'd like to introduce Miss Celestina, if you don't already know her. She works with me in Sunway Medical Center, and we go back a long way. When she graduated, she was a cardiac nurse and working with me in the cardiac ward in SJMC, but we have since then moved on to Sunway Medical Center. And she has also expanded in her career and went on to become an educator and now a diabetic counselor. So without further ado, Celestina.
Hi, thank you so much, Dr. Betty, for that wonderful introduction. So I'm one of the 3 diabetes educators in Sunway Medical Center. So today's talk is basically on diabetes management for nurses. It says a lot of recap on what the nurses should probably already know, but maybe just to sharpen their knowledge, and feel free to ask questions, later on in the session. So just a little bit of data here. This is what I could get for you all from the IDF Diabetes Atlas. Hold on, let me just clear this. Yep, sorry. In Malaysia Diabetes Report from the year 2000 to 2045. So they actually did a prediction on the number of patients that they would expect to find diagnosed with diabetes. And as you can see, the numbers are actually growing. We're now at 2021, we've already passed. And in 2045, the numbers are expected to reach really, really high targets. Now, the other thing here is also the National Health and Morbidity Survey that was done in 2019. One of the key findings is that 1 in 5 adults in Malaysia have diabetes. And that's looking at about 3.9 million patients aged 18 years and above. So what is diabetes? Diabetes is a condition in which the beta cells in the pancreas does not produce enough insulin, or that there is actually insulin resistance in the muscles and adipose tissues. So when you talk about diabetes, you generally talk about type 1, type 2, and gestational diabetes. Most of the admission into hospitals are mainly type 2 diabetic patients, although saying that, we are actually now seeing quite a few type 1 diabetic patients as well. Now, for type 1 diabetic patients, they are mainly children or young adults. They are very insulin dependent as the pancreas doesn't produce any insulin. For type 2 diabetic patients, they tend to be diagnosed more in adulthood, but on saying that, we see a trend of more young children coming in with type 2 diabetes. They are non-insulin dependent. Their pancreas produces insulin, but it may not be at the sufficient number, or that they are actually resisting the insulin that is produced. Whereas for gestational diabetes, obviously women during pregnancy, most of the time diagnosed in the 2nd trimester, and the pancreas is unable to produce enough insulin or the extra insulin needed during the pregnancy. So in a hospital setting, as part of the healthcare team, nurses are very important. We play a very important role. We spend a lot of time in the units caring for patients and patients with diabetes. So we are also, as nurses, most often the first healthcare team member to interact with the patient. And hence we apply our knowledge, our training, our skills to educate and motivate patients with diabetes. So when a doctor has ordered a treatment plan, it is the nurses who actually implement it. And over the course of the hospital stay, As nurses, we spend a significant amount of time caring for patients by assessing, getting blood glucose readings several times a day, documenting their meal intakes in the IO chart, and also giving medications either orally, subcutaneously, or intravenously. So it is important that our knowledge is up to date and that our skill techniques are also up to date, as all this will affect the quality of care given to patients with diabetes. Now, when you look at admission, history taking is an important part of patients' admission into hospital. So when you look at history taking, obviously it's important to document the type of diabetes, how long patient has the diabetes for, and what current medication the patient is on, and what is the dosage. Now, you also need to assess the patient's need for diabetes as well as nutritional education. Does the patient perform any self-monitoring of blood glucose at home? Do they even have their own glucometer set? Or are they borrowing the glucometer set within members of the family? Or are they relying to go to the pharmacy or the clinic to get a periodically glucose reading check? Are the patients compliant in taking their medication? Are they injecting their insulin technique correctly? Do they have hypoglycemic events at home? Now, all this is important because this history taking will help to assist the doctors as well in planning the treatment plan for the patient. And patients who are admitted in hospital, diabetic patients, they often find that there is a change in the diet that they have been usually taking at home. Most of the patients tend to eat a lot at home when they come into hospital and they are put on the hospital diet, which is a diet that is mainly controlled in regarding to portions of carbohydrate, protein, as well as fiber. Patients, some of them may not be taking medications regularly at home, and when they come into hospital, medications are given routinely. And all these routine good schedules that we do in hospital can actually adversely affect patients' blood glucose levels in hospital as well. Now, patients can have hypoglycemia mainly because of NPO status, or patient also can have high blood glucose readings from medications that have been started, especially steroids, or if they are actually having an infection or coming in with any acute illness. Proper timing of blood glucose testing as well as the medication administration can reduce the risk of hypoglycemia as well as hyperglycemia. So for blood glucose monitoring should be done for all patients admitted with history of diabetes or those admitted with hyperglycemic symptoms. This is normally typically the standard timing for blood glucose to be tested. A fasting reading, before lunch, before dinner, and a bedtime reading. There are some doctors who actually require a 2-hour post-meal readings. Now, it is important that when we check blood glucose, we are looking at timing that the blood glucose test has actually been ordered for. Of course, when you are doing fasting readings or before meal readings, it is important to ensure that you get the cooperation of the patient. Patient understands that the blood glucose testings are required to be done at these times and that they do not eat before the blood glucose testing has been done. Or if for patients who are on 2 hours post-meal readings, you need to make sure that the patient is aware that by the time you start to eat, 2 hours later, I need to come and check your blood sugar, and the patients don't accidentally eat or drink anything. So it is important that you include the patient in your treatment plan. And of course, whenever you are checking the blood sugar, you always need to ask the patient whether they have eaten or drunk anything prior to the test. Now, for post-meal readings, you need to report to the doctors also on the portion of the carbohydrate meal the patient has taken. Now, here we also discourage patients from taking home meals. Patients who have food brought into hospital, they have a tendency to eat the meal that has been served in hospital as well as the meal that has been brought from the house as well. So this can actually have an effect on the blood glucose readings the readings, especially the post-meal readings, can be high, and sometimes even the subsequent pre-meal reading as well. Now, there's a little tips that we can use when we're doing blood glucose testing. There are lenses that can be adjusted when it comes to the depth of the lancet. If you see here, the yellow color lensing device, as well as the purple color lensing device. The yellow color lensing device, you cannot adjust the depth. But for the purple color lensing device, by default, when you get it, the depth is always adjusted at the center. So for patients, or if you've ever tried using this on yourself, you will realize that using the lancet at this depth is actually quite painful. So prior to using lenses, you should ideally adjust the lancet to the minimum setting. We also encourage pricking at the sides of the finger to avoid the thumb and the little finger as well. And try and rotate patients' fingers when you are testing blood glucose so that we are not always pricking at the same side. Wipe off the initial drop of blood with the gauze or cotton. Use second drop for testing. For children who require hourly or 2-hourly blood glucose testing, there is a suggestion to use the fast click drum lancets to minimize trauma or pain. Now, these lancets have built-in needles, so patients don't actually see the needles that are being used, and the depth sensitivity is very minimum, so the pain threshold is actually very, very less. Okay, now let's talk about hypoglycemia. Now, hypoglycemia can be a very life-threatening event. Common causes of hypoglycemia in a hospital setting can be due to a change in the eating status, as in a patient who has been given medication, diabetic medications, and are suddenly ordered to be kept NPO. Or maybe too much of insulin was given, or the insulin was not given in relation to the meal that the patient needs to be taking. Inadequate carbohydrate intake can also cause hypoglycemia. Patients who are vomiting, or when there is any change done in an NG or TPN feeding regime for the patient, and the medication has not been adjusted accordingly. Now, patients who are on steroids as well, if you reduce the steroidal dose and if patients are on insulin, you will find that there is a drop in the blood glucose readings as well. So all this can affect, can bring on a hypoglycemic event for the patient. So what is hypoglycemia? Hypoglycemia is defined either by one of the following 3 conditions. You have a low plasma glucose level, which means that your blood glucose level is less than 3.9 millimole. But on saying that, there are some patients who have hypoglycemia symptoms when the blood glucose levels are at 4 or 4.1 or 4.2 millimoles as well. There is a presence of autonomic or neuroglycemic glycopenic symptoms. And these symptoms are actually reversal by carbohydrate intake. So this is a slide to tell you what are autonomic and neuroglycopenic symptoms. So for autonomic symptoms, you have the trembling, palpitations, sweating, anxiety. Patients complain of feeling hungry, nausea, tingling sensation. For neuroglycopenic symptoms, they have difficulty in concentrating. Patients become confused or weak or present with stroke-like symptoms. Some patients can actually be quite drowsy, or they complain of vision changes. They have difficulty speaking. They complain of headaches and seizures, as well as coma. Okay, so this is just another picture to show you hypoglycemic symptoms. So these hypoglycemic symptoms can actually be classified into 3 different levels. So for level 1, you're talking about blood glucose readings that are less than 3.9, but they are more than 3. So This is recognized as a threshold for neuroendocrinic responses to falling blood glucose in patients without diabetes. But for readings that are less than 3, threshold in which the neuroglycopenic symptoms begin to occur, and they require immediate action to resolve the hypoglycemic event. A severe event or a level 3 event is categorized by an altered mental state or a physically function that requires assistance from another person to help them in their recovery. So treatment of hypoglycemia, the aim is to detect and treat a low plasma glucose level promptly. You also want to eliminate the risk of injury to the patient and also to relieve the symptoms quite quickly. Now, you also want to ensure that you avoid overcorrection of hypoglycemia, especially in repeated cases, as this will lead to poor glycemic control and also weight gain as well. So this is generally a diabetic patient's reaction to low blood glucose. When they have symptoms, they feel that this is a time that they can eat or drink anything they want, irrelevant of the volume, to bring up the blood glucose, because symptoms of hypoglycemic is really not a symptom that is very nice that patients enjoy having. So this is the time that they will actually eat and drink as much as they want to reverse the symptoms. However, in doing this, what you actually find is that the blood glucose levels will then just shoot up, and it takes a longer time for them to bring down the blood glucose levels once they have overcorrected it. So there are certain steps that you would use to treat hypoglycemia. For level 1 and level 2 hypoglycemic levels, patients should actually have what we call a 15-gram of simple carbohydrate. So you're talking about, say, a tablespoon of honey or 1 tablespoon of Milo, 150 to 200 mils of fruit juice, orange juice, or soft drinks, or even if you're going to use sugar, then you're talking about 3 teaspoons of sugar, or 3 sachets of sugar. Now you need to recheck the blood glucose levels after 15 minutes. Okay. Now this is something that, if you notice, it is not often done regularly in the ward setting. So sometimes when we actually go around and we check the blood glucose levels of patients who have hypo, we find that probably the blood glucose levels are rechecked after 30 minutes, after 1 hour. And this is not the guidelines on how you would actually manage hypoglycemia. Now, if after 15 minutes and the blood glucose levels are still less than 3.9, you need to add on another 15 grams of simple carbohydrate to be taken again to the patient. And then 15 minutes later, you would recheck the blood glucose levels again.
Will you immediately give IV dextrose?
Not for a patient who is alert.
Oh,
if they're alert, if they're able to eat and drink, you would not give IV. Of course, if for some reason the patient is MPO, right, then yeah, it would be indicating an indication to give. Now, if the patient is unconscious, please do not feed the patient, okay, because you do not want the patient to choke, to aspirate. So this is when the IV boluses of 50% dextrose will come in. But if in level 3 and the patient is still conscious, you would give 20 grams of simple carbo. 15 grams is actually not enough, okay? But if the patient is unconscious, again, IV dextrose 50%, or a D 20%, run over 15 minutes. Now, if you're going to give IV dextrose 50%, it's very thick, very potent. You have to be careful of extravasation there. So it needs to be given slowly over 1 to 3 minutes. Now, once hypoglycemia event has actually been reversed, patients have a risk of falling into hypo back again. So in order to prevent this from happening, you need to give them what we call a complex carbohydrate meal or snack. So if, say, for example, the patient is having a hypo and it's about to be lunchtime, get the lunch meal for the patient and get the patient to eat, you know. But if, say, for example, it is not a meal time, give the patient a snack. And the snack has to be a complex carbohydrate snack. Now, of course, after the event, it is important to evaluate why the hypoglycemic event actually happened, you know. So, and also you also need to educate the patient so that it does not happen again. Some of the common causes is insulin given, patient, the food is there, patient has been instructed to eat, but patient doesn't eat. A phone call comes in, patient takes a phone call, or suddenly decide, you know, hey, maybe I should go and have a shower first or something. And all this delay in meals, especially when insulin has already been given, can bring about hypoglycemic events as well. So when a patient has a hypoglycemic event in the hospital, of course, the doctor will then review the medication doses, OHA as well as the insulin, and adjust it accordingly to prevent. So just a little recap about the 15-15 rule. 15-15 rule is there to guide you to remember how to treat hypoglycemia. So when there is a hypoglycemic event, you would eat 15 grams of, eat or drink 15 grams of simple carbohydrate. You wait for 15 minutes for the sugar to get into the bloodstream, and then you would recheck the blood glucose levels after that. So these are examples of 15 grams of complex carbohydrate that can be given to the patient as a snack. 1 slice of bread, 3 pieces of plain crackers, oats, if you know you have it, or a patient has oats by the bedside, a plain bun, fruit, like an apple, a small banana, and very sad, but only 5 pieces of grapes. So remember, hypoglycemic event is actually quite serious, but it can actually be treated. Okay, so we move on a bit to DKA, diabetic ketoacidosis. Diabetic ketoacidosis is an acute, major life-threatening complication of diabetes characterized by high blood glucose, ketoacidosis, ketonuria, and that requires emergency treatment. Now, most of the times, these patients will actually be admitted in the ICU, HDU setting. Mainly occurs with type 1 diabetic patients, but it's also not common. It's also common to be seen in some type 2 diabetic patients as well. For type 1 diabetic patients, it's a state of absolute or relatively no insulin or relative insulin deficiency. Now, this condition develops when your body cannot produce enough insulin. As you know, insulin plays a key role in helping glucose, a source of energy for your muscles and tissues to enter into your cells. So without insulin, your body then begins to break down fat as fuel. And this process produces a buildup of acids in the bloodstream called ketones, and that leads to decay if it is left untreated. So most of the common causes is inadequate insulin treatment or non-compliance to insulin. It can also be because of newly diagnosed diagnosis of for diabetes for the patient. Some acute illnesses do bring on DKA as well, infection, sepsis, CVA, MI, acute pancreatitis, and there are certain drugs, antipsychotic drugs especially, as well as your SGLT2 inhibitors that can bring on DKA as well. Now, clinical symptoms, decay normally happens pretty quickly. The earliest symptoms are usually excessive thirst, frequent urination, weight loss as well. Some people complain of feeling very, very hungry as well. Nausea, vomiting, abdomen are also present. Generally feel very tired, lethargic. Some complain of blurred vision, and of course, the blood glucose levels are actually very high. And if they do not seek treatment quickly and the duration of the hyperglycemic status progresses, neurological symptoms does set in, and they can actually have a reduction in alertness, or they can actually become unconscious. So clinically, these patients are generally unwell. They have what we call Kussmaul breathing, very dry, decreased reflexes. They have this fruity breath odor, very tachycardic. Blood pressure is also low, very fast breathing. Some patients come in with hypothermia or high fever if there is an infection present. They can also be confused, complain of abdominal tenderness. They can also be brought in a coma state. So what here we need to do is that we need to look at hydration status, correction with intravenous fluids, electrolyte imbalance, especially potassium loss as well, correction of the high blood glucose with insulin therapy, and of course treat the precipitating factors and educate them to prevent complications. So most of the time, these patients, from the nursing point of view, will be on hourly blood glucose testing. And when the levels are a little bit more stable, then it drops down to 2 to 4 hourly testing. Of course, vital signs and IO chart is very important here. There will be repeat sodium bicarb and potassium blood tests taken, as well as renal 2 and ketone levels checked in the urine and blood. Now, of course, if you do not see an improvement in the blood test readings, and you do not see an improvement in the blood glucose readings, obviously always check and see that the insulin infusion pump is actually working correctly, because sometimes insulin is not going in and the blood glucose levels remains high. Okay, so yeah, check your equipment. It's a very important part here of nursing job as well, because it does happen. Okay,
so without even a warning sign?
Some do, but you see, sometimes you will actually have leakage. So your insulin is actually flowing, but it's actually flowing out of your cannula.
Oh, I see.
So,
it's like, oh, I get it.
Yeah, so your medication is going in through the pump, but it's not just going to the patient, you know. So okay. Yeah, so these are things that yeah, as nurses, you know, we need to check basically. Now, timing of medication is also very important. So these are the normal common oral anti-hyperglycemic agents that are given. So technically, if you look at it, you're only looking at sulfonylureas that need to be given mainly before meals when it comes to tablets. So there's a difference between the dimacron and the dimacron MR. So for dimacron, which is the old white round tablet, is always 30 minutes before the meal. And for dimacron MR is immediately before the meal. That's just how the pharmacology function of the medications are. But for the rest of the medications, you're actually talking after meal. For metformin, it's important to be given after meal because it actually helps to reduce the gastric disturbances, abdominal discomfort that patients can have with taking metformin. Now, when you talk about insulin, the insulin is categorized under rapid acting, short acting, intermediate acting, long acting, premix. And when you talk about non-insulin injectables, you're talking about your GLP-1 receptor antagonists. We used to use Victoza a lot last time. It is still being done, it's used, but Victoza is something that needs to be injected on a daily basis. And then over the years, they moved on to what you call a weekly injection for the GLP-1. So you had things like Bydureon, Trulicity, and Ozempic as well. These are weekly injections, so it's a lot more easier sometimes for patients than to have to inject themselves on a daily basis. When you talk about insulin, there are certain things that you need to remember. Onset of action, which is basically the length of the time before the insulin reaches your bloodstream and start working. Peak is talking about the time the insulin is actually at the maximum strength or working the hardest to lower the blood glucose. Duration is basically how long the insulin is working in your body. When you're talking about basal, you're talking about mainly long-acting insulins that work throughout the night and in between meal. Bolus are meal insulins. They have a shorter duration. And premix are just combination of your bolus and basal insulin. Now with insulin as well, it's also important to know timing. So when you talk about what you say, analog and regular insulin, so analog insulins are your new modern insulins. So these are the insulins that you would inject immediately before meal. So things like your meal insulins, your rapid acting like your Novorapid, Humalog, and Epidra is immediately before meal. Your Atrapid and Insurgent R, it is 20 to 30 minutes before meal. For premix insulin is always immediately before meals, like your Humamix, your Novamix, your Humalog Mix 25, Humalog Mix 50, and your Ryzodac. Now for your premix, like your Mixtard and Insurgent 3070 is 30 minutes before meal. For your long-acting insulin like Levemir, Tojo, Lantus, and Basalog, they can be injected at night or they can actually be injected at the same time of the day. And there are patients who are on these insulins during breakfast or maybe even before lunch, as long as it's at the same time of the day. Now for intermediate acting like Insulatard and Insurgent N, it's normally always injected at bedtime. For GLP-1 receptors like your Victoza, Bydureon, Trulicity, and Ozempic, these are normally injected at the same time of the day or even the same time of the week as well. So this is just a little step to go back and refresh on how to do the insulin injection technique. So of course, if you're using the insulin syringe and the cartridge, very important, wash your hands before you handle the syringe in the cartridge. Make sure you check that you actually have the correct insulin. Insulin has not expired. If your insulin has been kept in the fridge, you would warm the insulin initially by rolling it, the cartridge between your hands. Remember, cloudy insulins, they need to be mixed. So it's inverted 20 times before every use, and you cannot shake the cartridge vigorously. Wipe the top of the cartridge with alcohol swab. Remember, these cartridges are most of the time cartridges that can be shared between patients, right? So it's important that you do not bring in any cross infections, basically. So wiping the top of the cartridge with alcohol swab will minimize that risk as well. Now, because your cartridge is glass, you need to make sure that you actually pull back the plunger for the syringe to draw out the air of the volume of insulin that you need back into the cartridge. That means you inject back that dose that you need of air into the cartridge. And turn the cartridge upside down, obviously, pull back the plunger to draw out the desired dose, remove any air bubbles, and remove the needle out of the cartridge. So important, you clean the injection site with alcohol swab. Remember, this is in hospital. For patients who are doing injections at home, they may not need to use the alcohol swabs as well. Okay, so this part about pinching the patient's skin, right? Skin fold. So if you have a patient who is very thin, yes, you do need to pinch up the skin fold of the abdominal area. If you have a patient who is overweight, normal weight, obese, you do not have to pinch the skin. But it always helps if you actually hold the patient's skin, because in some ways, psychologically, I always think that it's kind of giving comfort to a patient when you're going to do something to the patient, that you will have one hand holding the patient and the other hand holding a syringe. So of course, you insert the needle at a 90-degree angle and depress the plunger, and you remove the syringe afterwards and release the pinch if you're pinching. And disposal is very important in your sharp spin. Now, if you're using an insulin pen, it's still the same technique. You need to wash your hands, check that you have the correct insulin and your insulin has not expired. If it's taken out from the fridge for a new pen, then of course you need to warm it up between your hands. And if it is a pre-mixed insulin or cloudy insulin, then of course you need to mix it as well. Attach the needle, and remember a needle are single use. So for all pens, you actually have to prime the pen first because there's a little bit of air bubble in the pen that you have to discard before you use. So you would dial 2 units and you would remove the 2 covers of the needle, and you will make sure that you prime the insulin pen with the needle pointing upwards. Sometimes we see people pointing the pen downwards. Of course, the insulin will come out, but the air bubble will still remain in the pen. So make sure the needle is pointed upwards, and you must observe at least a drop of insulin at the needle tip before you move forward to dial your dose. If you do not observe that drop, you dial 2 units again and you redo the steps again. So of course, you dial the prescribed dose, and at the patient, inject the needle in at 90 degrees again. And once you have depressed the plunger totally to 0, you need to count slowly for 10 seconds before you withdraw the needle from the skin. Now, there is no recapping, okay? And there is no using your bare hands to remove needles. I say this because I've seen it. Okay, so needle stick injury among nurses is something that can happen if you recap or you remove needles with bare hands. So remember that you need to use the arterial forceps, the metal ones, not the plastic ones that do not have any grip. So use this to remove the used needles and discard directly into the sharps bin. This is something that we have been going around teaching patients as well as nurses, is talking about rotation site, where you would inject insulin. Commonly, patients always get asked, where did the nurse inject this morning, or where was your last injection? So sometimes patients will say, oh, I don't know, it was here, can you do it on this side? Or sometimes the patient will say, you can just inject anywhere you like. But when you have, you do not have a consistent site rotation, there are risks of lipohypertrophy being formed. So what we've actually been doing is that we've actually been teaching nurses as well as patients how to do the site rotation by dividing the abdominal region into 4 different quadrants and using each quadrant for 1 week. So the easiest way for them to remember which quadrant to actually use is to start off at the right side of the abdomen, upper quadrant, and you use it for the dates of 1 to 7 on the calendar. 8 to 14, which will be week 2, will be the up left quadrant. Day 15 to 21, which is week 3, will be at the lower left quadrant, and day 22 to the end of the month, week 4, will be at the lower right quadrant of the abdomen. Now, if you do not have proper or site rotation, this is what can actually occur. You have lipoatrophy and lipohypertrophy. Now, when this actually happens, what actually occurs here is that insulin is actually pulled in areas like this where you have the bumps. And the doctors keep adjusting the insulin dose because the blood glucose levels are not coming down. And when this happens, the doses keep getting adjusted. And then patients come and they meet wonderful nurses like us who educate on site rotation. And patients then inject the high new dose onto a site that has no lipohypertrophy, and patients have a high risk of going to hypo. So we need to avoid all of this. And if you have patients coming in, being admitted with history of having insulin, make it a point to check, observe patients' abdomen area or wherever they are injecting, because some patients tend to inject at the arm area as well, and check and see whether you have any lipohypertrophy. Now, this chart is important for patients because when patients go home, they need to be able to manage their diabetes as well. So diabetes planning is important for them. And this is also an important opportunity to help patients to address diabetes control, both for newly diagnosed diabetic patients and for those patients who, whilst in hospital, have a change in their medication regime as well. So when patients are planning for discharge, one of the things that you need to ensure is that when they go home, they have personal glucometer sets for them to check their blood glucose. There is a logbook or diary for them to record, because when they come back for their appointments, they need to have all these things to show to the doctor the readings. They understand how to take their medications or insulin and how to self-inject correctly. They're also taught on hypoglycemic and hyperglycemic symptoms and how to manage them as well. So health literacy is important. This is something that came out in the National Health and Morbidity Survey in 2019. And it says that 1 in 3 adults have low health literacy. So health literacy is basically an ability to find, to understand, and to use health information and services needed for everyday health decision making. Why this is important is basically they need to understand the health risks and factors involved in practicing a healthy lifestyle, understand how to take their medications correctly, analyze risks and benefits of treatments wisely, and also help them to organize their appointments correctly. Now, in addressing health literacy, one of the ways that can be done is actually for some patients, instead of us verbally explaining everything to them, use of graphics or pictures for teaching can actually help patients have better understanding. Patients like to look at videos. So, if you have a video on certain aspects or whatever topics that you're teaching about on diabetes, you can actually show the patient. Getting patient to written demo to you is very important, because this will help you to check the patient for their understanding. And in Sunway Medical Center, we also have what we call these follow-up phone call services that the diabetes educators at the Diabetes Care Center do. So we actually monitor patients' readings on maybe 2 or 3 times a week, or some patients who are not do not need so constant or close monitoring once a week. We actually call them up to get their readings, and we update to the doctors on their readings. So all these things will actually give us an opportunity that when we get readings on patients and readings are high, we use those opportunities to re-educate the patient again on their diabetes management whilst they're at home. So these are just certain things to tell you about blood glucose monitoring. Very commonly for patients, they use the finger prick glucose testing using a glucometer. For type 1 diabetic patients who are on insulin pump, some of them may actually be using what we call the continuous glucose monitoring device, where it can actually be linked to their insulin pump as well. And this is something that's quite new in the market in Malaysia, but not new in Singapore or overseas. It's what we call the flash glucose monitoring. So this is something where you can actually fix a sensor to your arm. Generally, it's at the upper arm. And you would use a reader here to scan the sensor to get a blood glucose reading. Now, remember, when you use the flash glucose monitoring, you are not looking at peripheral glucose readings, but you're looking at interstitial fluid readings. So there can be a variance in the readings, but when you use these sort of devices, you would look at the number, you would also look at the arrow direction, and you can also look at the glucose reading trend that the reader can actually, when you review a history. Now, generally, flash glucose monitoring devices are used for patients who have challenges in managing their diabetes, but there have been some incidences where it's actually used as inpatient setting for patients who need continuous or regular glucose monitoring as well. And we have used it on a few of our patients in Sunway.
How do you insert that device?
It comes in a set. So basically you have to kind of open the attachment and you just put it on your upper arm here. You just press it and you remove, and that sensor is then stuck there with there's already the tape there. So that tape is the one that actually
Is
holds
there a
the device.
needle there? Is there a needle?
There is an introducer needle when you insert, but when you remove it, that needle comes out in the insertion device.
I see.
So you're actually using that existing filament that is in just underneath the skin to do the reading. No pain. We've all tried this. I've tried it. I've used it for
You
2
have
weeks.
tried it yourself?
Of course, we try everything that is new because in order for us to teach patients, we need to know how to use it and how to live with it. You know, it's
So
on for 2
you
weeks.
insert it for the patient, or the patient insert it by themselves?
Okay. So for the first time we actually insert for the patient, we teach them. Subsequently, they can do it by themselves. We have a lot of patients who actually come to buy the sensors from us and they do it themselves. Very easy, no pain.
And do they need to change it how often?
Okay, so when you fix the sensor stays on for 2 weeks. And in that 2 weeks, you can use your reader to scan however many times you want in that 2 weeks. But of course, we tell patients don't go crazy, huh? Don't keep scanning every 1 minute. We have patients like that.
Yes, I understand.
Because it's something new, and what's my reading scan? What's my reading scan? I just eaten half a bowl of rice scan. So of course when you come back to see the doctors, doctors say, I can make head or tail. I don't understand what is going on here. So when you tell patients there must be some logic. You want to check a pre-meal, 2 hours post-meal, pre-meal, 2 hours post-meal. So there's consistency in timing so that it's easier to interpret the data that is being given. And one thing also about this is that when you download the data, it tells you your time and range. So we are not looking so much at HbA1c. I mean, it gives you a predictable prediction of a HbA1c, but it also tells you how much of percentage of time you actually spend in good glycemic control or hypos, and how severe the hypos are.
But for example, right, when you fix it, right, do you fix it like you do with the rotation of your insulin?
Yes. So normally we'll tell them first one will be on your, assuming they're going to put more than one sensor, right? So 1 week for the first sensor, for 2 weeks, maybe your left arm. The next one on your right. Then go back to your left. Yes, we do that. But the other thing that you need to stress to patient is for the first 24 hours, because this is looking at interstitial fluid, your readings are not accurate. Remember, there is a variance between the finger prick as well as interstitial. So you cannot do comparison. You cannot say, I prick my finger now and my reading is 5, and I scan and my reading is 3. And why is it like that? There is always a lag in the reading. So you look at number, you look at arrow direction, and you also look at symptom. So if you scan and your reading is telling you is 3 and your arrow direction is stable, you're actually not having a hypo unless you have symptoms. Then yes, finger prick and counter check.
Is it useful for, let's say, deciding on the amount of insulin after a meal or before, let's say something that I've eaten that I'm not sure how much will increase my sugar level?
Can, because you can do your post-meal reading, but I mean, you will need to do a few for you to gauge how much is your,
that's right.
And a lot of times it's actually also good to looking at the portions of carbohydrate you're going to have in that meal. This is something that is quite good also for type 1 diabetics patients because they need to monitor quite regularly. And especially for children, right? So the parents don't actually have to prick their fingers, when they're sleeping at night. They have a 3 o'clock reading that they have to do. You just take the reader on it and you just sort of wave it over the sensor and you get a reading. It can even be over. Yeah, it is actually. It can even be over the sleeve of the baju that you're wearing, it picks up the reading.
Oh, even over the sleeve.
Yep.
So for, let's say, the Muslim ladies or people
no issue.
Yeah, no issue at all. Yeah? Oh, nice.
And you can have a bath, no issue with that. Yep, it's waterproof.
Is there many brands in the market or just one brand?
Only one brand in Malaysian market, which is a Freestyle Libre.
Yeah, I thought.
Yeah, yeah.
Okay.
Okay.
Sorry.
So, no, it's okay. It's okay. Yeah, but that is currently the only brand in Malaysia. I mean, we've been waiting for years actually for it to
Yeah.
come across. Yeah. So,
Okay, so the next question is how much would it cost?
okay, standard price, whether you buy it from us or you buy it from Lazada, fixed price. Reader is 262 ringgit. Sensor is also 262 ringgit.
Sensor can last forever, right?
Sensor will last you for 14 days.
Oh,
Reader,
okay, reader can last you forever.
correct. And the reader is dual function. You can also buy the freestyle strips that you can actually use it as a normal glucometer as well. So it's a dual function. But if you,
I see.
yeah, so these are things for patients who have to check regularly, you know. So you weigh in the cost of pricking finger 5, 6, 7 times a day. You weigh in the cost of the strips, the needle. This is easy if you have to do multiple testings, especially when blood glucose levels are very haywire.
Okay.
All right. But I also have patients who continuously use this because they just find it a lot easier, and I don't have to prick my finger. Yeah.
Yes.
So
It's yeah. Especially it's also quite fun.
well, I mean, if you really want to know exactly how much of carbohydrate you are going to plan to have for the meals, yeah, you use something like this because a lot of patients, when you tell them you need to check your blood glucose, you know, okay, wash my hands, I got to get my needles, I got to get my strips, I got to open, I got to set everything up. This, I just take it, I press on and I wave, and that's it. Nobody even needs to know what I'm doing, you know, and it can be done so discreetly. That's, I find, is the beauty of this, basically. Yeah.
Okay, Marina raised her hand. Marina, would you want to ask a question? Can you keep the question till the very end first? Yeah? Okay. We better continue?
Yeah, okay. So basically, this is just to let you know that our services in the Diabetes Care Center in Sunway Medical, of course, a lot of it is educational counseling to patients to improve their understanding of the disease, potential complications, healthy lifestyle, hypoglycemic management, medication, insulin injection technique, coping with insulin injections itself, doing the how to do the blood glucose monitoring, phone follow-ups. We also sell devices. We introduce patients to the insulin pump as well, and we do food assessment and screening and education as well. We have also embarked on what we call a digital therapeutic and lifestyle coaching using the Help to Sing platform. So this is an app that patients download, and using this app, they can update us their blood glucose readings, take in pictures of the food. They can actually now put in blood pressure readings, weight as well. So when they sign and link up with us, we can actually view this live almost immediately after they upload any reading or picture at our clinic in the center. Of course, we only look at it during office hours when we're working, but this is useful for patients who have to very regularly update us on readings, or patients who need constant guidance from us to help them to manage the blood glucose. So with that, I thank you.
Oh, how many times the needle can be used? Which needle, Nazira?
Yeah.
Thank you. We will take questions first before I thank you. Any questions?
Option B.
Very good talk. Very interesting.
Thank you, Dr. Betty.
Okay.
Okay, so maybe I answer the question about the needles first.
Yeah, that's right.
Yeah, so again, if you're talking about the insulin needle, it's single use. Why it's single use? Well, because of technology, insulin needles nowadays are shorter and they are finer. So if you were to reuse the insulin needles, the chances of it breaking would be there, or bending would be there. But if you're talking about the finger prick needles, the lancets, right? Normally we will tell patients 2 or 3 times, you know, because
you can use so many.
this is not the single-use lancet you use in the hospital. This is the lancet you use in the glucometer set that patients have, because they do not share it. It's for themselves only. They try to save money. So you can save money by reusing this needle to check your blood sugar. But of course, if it is used first time, it's very sharp, no pain. Use second time, a little bit blunt, maybe a little bit of pain. So that's why we normally say not more than 3 times.
And okay, I'm sure you handle a lot of children with insulin-dependent diabetes. How
Yes.
do you counsel the kids, not so much the parents, as it is quite sad for the parents, but how do you counsel kids that are like say 5 to 7 or even 8 years old?
I think that most important, for me, I feel that you have to counsel the parents.
You have to counsel the
Because,
parents.
yes, because if the parents, especially the mother, can accept and can cope, then it makes everything a lot easier. So of course it's very individualized. If the younger the children, you cannot be teaching that child a lot of things. They still depend a lot on the parents. So hence why you find devices like the fast click glucometer set, where the lancing device, you don't see the needle. Children don't like to see needles. Parents don't like to see needles also, for that matter. But you allow parents to test all these things on themselves first, so that they know how it feels.
I
Yes.
see, okay.
Then you bring it to the children. So tackling the parents is always the issue and the first thing.
Okay, and then so basically if the parents do it on themselves, they will demonstrate it to the children to show that it is
It's
not
not,
painful.
yeah. And sometimes when they do it themselves, when the child say, oh, mommy, daddy, is painful, so if the parent doesn't try it on themselves, they will never know whether it is painful.
Oh, okay.
So, and when they do it on themselves, and then they do it on themselves in front of the child, it's like, oh, mommy and daddy can do it. So yeah, it helps.
Okay, Miss Lok Mi Xiang, do we need to counter check the sugar level with the finger prick testing when the patient is using flashing glucose monitoring? If yes, under what circumstances?
Okay, so you look at arrow direction and obviously at patient symptom. If patient says my number is showing 3, my arrow direction is heading downwards, please check, because your arrow direction that is heading downwards tells you that there is a hypo that is happening or going to happen. And also whenever patient feels that whatever reading that is being shown, even a high reading for that matter, the reading is 20 for instance, or 18 or something, and you want to counter check, then yes, please, you need to counter check. So we always tell patients, if the reading doesn't match how you feel, also counter check.
Okay, there's another question which I think Raha asked. May I know the way to become a diabetic counselor? Okay, that's a very good question. We need more, I think.
We definitely need more, and I think a lot of hospitals are finding that there is a need for diabetes nurse educators. So of course, post-basic is a post-basic course that you need to do, and then a lot of it is
Post-basic is in what?
AKM, Kerajaan.
In Kajang.
In Kerajaan, government sets out the post Kerajaan.
Okay, post-basic, but
in
the
diabetes.
post-basic as in post-basic in diabetic counseling.
Yes.
Oh, I see. Okay.
Diabetes management. It's a 1-year course now. It used to be 6 months.
I see. Okay.
Yeah, but not to publicity if you like, but there are some private universities that actually do the postgraduate diploma in diabetes management. Yeah.
I see. So it is not on the job kind of thing. It is a really structured program to do this, become a diabetic counselor.
It is a really structured program, but of course you need on the job experience as well, because even though you've actually learned what you can theory, you still need to have the practical setting to practice. So a lot of things that myself included, I learned on the job, and I learned from my seniors, so this is how we learn. And we learn from our very wonderful endocrinologists as well, because they do teach us as well.
The endocrinologists, right?
Yes, yes.
Yeah. Okay. If there are no more questions, we will end here. I'll stop the recording.